This meeting is being recorded.
Good evening, everybody. Thank you for joining us for our lecture with Dr. Danielle Ponzio, one of our joint replacement surgeons here at Rothman Orthopedics. Tonight, she is going to be talking on staying active before, during, and after joint replacement surgery. Her focus of tonight's talk is on the non-surgical treatment for hip and knee arthritis. She's also going to touch on total knee replacement, a partial knee replacement and what those are, total hip replacements, and revisions for both hip and knee replacements.
So to get into our topic a bit, I'm going to start out by just giving you an overview regarding arthritis. And first of all, arthritis means that the padding in the hip or knee joint has been worn through to the point where you can develop areas of bone-on-bone contact, which generates pain. The padding in the hip is known as cartilage, so that's often how you'll hear things referred to. The most common cause of disability in adults in the United States is arthritis. And by 2040, adults that are affected is projected to reach the number of 78 million, or 26% of the adult population. This chart here on the screen shows that the highest prevalences are in females, as well as the population of 65 years and older, where the prevalence approaches 50%. The American Academy of Orthopedic Surgeons has recommendations in terms of how to treat arthritis, and I'd like to highlight these top two that are underlined. Those are the strongest recommendations for non-surgical treatment of arthritis of the hip and knee, and that includes strengthening, low-impact aerobic exercise and physical activity, as well as weight loss. They also have strong recommendations in favor of anti-inflammatory medications, as well as tramadol. And then they actually have recommendations against some things like acupuncture, glucosamine, chondroitin, and knee scopes. So the idea of doing a scope to clean out arthritis. The inconclusive recommendations include bracing and injections. However, I would point out that we use injections quite frequently to temporarily provide relief from knee arthritis in particular. This is a study that highlights the benefit of exercise in an older population of adults, and it looks at a 14-year period and tracks those people over time to measure their pain. And what the study shows is that there's 25% less pain and less arthritis associated with individuals who regularly exercise in comparison to sedentary individuals. So it supports those recommendations that even if you have an arthritic hip or knee, moving that joint and using that joint in physical activity is really extremely important in terms of lessening the symptoms that come from the arthritis. So overall, in general, physical activity guidelines, and this is from the US Department of Health, is that you should get at least 150 minutes per week of moderate intensity activity, like a brisk walk, or 75 minutes of vigorous activity like running. In addition to that, it's recommended to get moderate or high intensity muscle strengthening activities such as weightlifting or even body strength training with things like yoga during the course of a week. The other main message I want people to take from this is that you should really do things to avoid inactivity. So getting some activity into your life is better than doing nothing. And the chart on the right side of the screen here gives us some ideas of things that you should implement in your day-to-day life. So starting to cut down on the time that is spent sitting in front of the computer or the TV and integrating things like lifting weights, stretching, and yoga, or more physically active activities like running, swimming, brisk walking, biking, tennis, hiking, basketball, skating, and then even everyday activities that you might not think of as working out necessarily, but taking the stairs, walking instead of driving, doing housework, cleaning, walking the dog, parking your car further. Those are easy ways to get in a little bit more activity, just doing day-to-day things. And we know that there are a multitude of benefits to physical activity, and this is a list of many of them there. Cardiovascular health, muscular strength, endurance, balance, coordination, weight control, personal satisfaction and sense of well-being, stress reduction, antidepressant, improving your bone density and thereby reducing hip fractures, improving blood pressure, cholesterol, reducing dementia, reducing mortality, and reducing type 2 diabetes. So all these things are really important. And so, that speaks highly of the role of physical activity in our lives and importance.
Dr. Ponzio, we have a question that just came in.
Okay.
The question says, should I push myself to walk, although my left knee is in a lot of pain most of the time?
Yeah, so I think that it depends on what's going on with your knee. And certainly the first step would be to get an evaluation, which generally is going to include at least an x-ray to see what's happening in the knee and what the degree of the issue is. But so if you're in a lot of pain where you can't walk, I mean, that really means you ought to get an evaluation sooner rather than later, prior to just pushing through it, because there are things that may need to be addressed. But in general, yes, you want to maintain some level of physical activity, and that may mean finding activities that don't bother the knee, that are lower impact, such as swimming or using an elliptical device or something of that nature.
To that point, there's a part 2 to that question. How much walking is safe when you're bone on bone?
So once you do have bone-on-bone arthritis, activity on that joint is not going to do significant damage beyond what you have. So you've already worn through your cartilage. So you can participate in physical activities without the concern that you're doing further damage necessarily. However, it may cause pain. So that's the caveat to that. And when you get to that point where the pain is really keeping you from doing basic things such as walking, climbing stairs, or even cleaning around the house, things that you need to do for daily living, that's when you may consider things like a joint replacement. Is that it? All for that? Okay, so moving on to the next slide here, a balanced diet, of course, plays a role in all of this and goes along with that piece of weight loss that can significantly help arthritic joints. And I just wanted to put this in here so that you all have this information, that we have registered dietitians at our Rothman locations, both in Pennsylvania and a couple of the offices in New Jersey. And I think that's a really important tool to have available to folks to make sure that you have the resources to make improvements in your diet if you're a person that can't quite get over the hump and get moving in the right direction. So then when it comes to the surgical side of things, which is what I spend most of my days doing, we talk about joint replacement a little bit and the role of joint replacement in treating hip and knee arthritis. So it is a well-established surgical procedure that is effective and durable, and it allows us to achieve pain relief. It allows us to correct the alignment of the lower extremity in people that have deformity from arthritis, and improve knee function, hip function, as well as quality of life. There is an increasing number of individuals that seek joint replacement at a younger and younger age as a means to maintain their active lifestyles and to restore their ability to participate in different athletic activities. So that population is growing each year. When we talk about hip arthritis, this is a diagram that gives you an idea of what that means. So like I said, it means that we've worn through the cartilage or the padding in the hip joint, and that's the area in between the ball and the socket. And the bone becomes very abnormally shaped, irregular, bumpy, and you get in areas of where bone is exposed to bone on either side, and the contact between those areas causes pain. The image on the far right here is a real femoral head, the ball part of the hip, and you can see where there's eroded areas where instead of having a nice cushioned white surface there, it's kind of abnormally colored and eroded. When you come to the office, our first step is going to be to look at some x-rays. And so this is an example of an x-ray of the pelvis, with the right side of the screen showing a normal hip where there's a joint space around the ball part of the hip, whereas the other hip clearly demonstrates a big difference. There's a deformed ball, or we call that the head of the femur, the femoral head. It has a lot of bone spurs, and there is no space there, no joint space or cushion, and therefore bone-on-bone arthritis. And in contrast to that x-ray, you see now an x-ray where there has been a hip replacement performed. So that whole area where that irregular bone that really didn't quite look symmetric or pretty was there, that is now removed. And in its place, we have a brand new ball and a brand new socket. And so I'll show you what those parts look like on the next slide, but you can see that this is symmetrical. It's going to relieve that bone-on-bone pain and restore range of motion to this hip. This is the breakdown of what those implants look like. So for total hip replacement, in the thigh bone, there's this device on the far left here that's called the stem, and that basically anchors everything in place. Attached to that is the ball part, which is made out of a ceramic, and it is right up against a plastic or polyethylene, what we call liner, that sits inside of a shell that's on the cup side. So there's a cup and a ball that sits within that, and that's what creates a nice smooth joint and gives you space back in your hip joint. Recovery, so after this surgery, typically patients are either going home the same day or spending one night in the hospital and going home the following day. We will put patients on blood thinners, and that's a baby aspirin 2 times a day for a period of 6 weeks. And that is meant to protect you from blood clots, which is a potential complication of this type of surgery. You are permitted to put full weight bearing on that leg right away after surgery, but I do ask patients to use a cane for a period of 6 weeks. And the reason for that is because that implant that we put in your hip joint is healing for that period of time. And so rather than being very aggressive early on, you want to be aware of the fact that you just had surgery. Healing has to take place before you can use that hip in the way that you're going to want to for the long term. The only therapy for hip replacement is to walk. So you do not have to go to see a physical therapist after hip replacement. Walking in the first 6 weeks is really all I want patients to be doing. At 6 weeks, once you hit that time period, you can start to return to non or low impact activities. So if you wanted to get onto a stationary bike or start to swing a golf club, those types of things, you can do that at around 6 weeks from surgery. 3 months from surgery is the time period when I allow patients to start to return to all other activities. So the higher intensity activities would include things like running or jumping. And the time period for that is around 3 months. And in people that are really looking to get back to serious things like running on a regular basis, I am working with them to make sure that they make a transition that makes sense and that they do it in a smart way and are listening to their body throughout that transition. By about 1 year, that is the time frame when people say that they, quote, forget about the fact that they had a hip replacement. Other things to keep in mind, driving is a common question, and typically the average is about 3 weeks from surgery before patients feel comfortable driving, but of course that varies, with some patients being a little bit quicker and others taking a bit more time. The majority of patients are able to return to sedentary type of jobs by 6 weeks, and more demanding physical occupations may take a little bit more time.
Dr. Ponzio, we have 2 more questions that came in while we're on this slide. One is, does physical therapy help prior to surgery?
So it depends on the individual. I do not routinely prescribe physical therapy prior to surgery. The one exception to that would be individuals that are, for one reason or another, severely deconditioned because of either their past medical history, and sometimes their arthritis has contributed to that. But I would say that that is in general a rare occurrence, and that most patients are sort of conditioned or fit enough to go into joint replacement surgery without physical therapy prior.
And we have one other question too. Rose, I see that you submitted a question, and I'm actually going to unmute you just so we can have a better dialogue about this to see what it is you're looking for. So go ahead, Rose. Rose, are you there? All right, I'll give you a couple minutes, Rose. If you want to go ahead and ask your question, I do have your microphone on, so just ask whenever you're ready.
Okay. I'll keep moving in the meantime. So I'll shift gears a little bit to talk now about knee arthritis. Similarly, here's a diagram to show you what that concept looks like, that typically you're going to have a knee joint with a space and a cushion that consists again of cartilage as well as the meniscus in the knee. And when you've worn through meniscus and you've worn through cartilage, that's a scenario where you begin to get bone-on-bone contact as well as bone spurs and narrowing in the joint space, which causes pain. The pictures on the right side of the screen, the top one there shows you a joint that has a lot of arthritis, and that area that almost looks like a piece of cauliflower or something is actually the kneecap, the patella, flipped upside down so that we're looking at that surface, and you can see that it's really irregular with a lot of extra bone formation. So that, in this patient, was causing a great deal of pain, of course, and so we clean that whole area up. And in the bottom picture, you can see the knee replacement with the brand new surfaces, as well as the resurfaced or replaced kneecap area. And so those smooth surfaces are going to remove that arthritis and the pain and allow the patient to regain their range of motion. Again, x-rays are the initial workup when you come to the office, and so these x-rays show you on the far left what a normal joint space is going to look like between the thigh bone and the shin bone, with an area that is open on the x-ray, and that's filled with the cartilage and the meniscus, versus the center photo where you see loss of that joint space and compression of that space such that the femur bone is right up against the shin bone. And then on the far right is an example of somebody that has arthritis, but not only just arthritis, but a lot of deformity in their lower extremities as a result. So they've got knock-kneed deformity in this picture, and we see quite commonly the other type of deformity, which would be an individual with bowed knees going the other direction. Those are things that our knee replacement can correct. So here's a picture of post-knee replacement on an x-ray, and you can see that the limb is nice and straight and that we've restored the space between the femur and the tibia, or the femur and the shin bone. So that space is nice and symmetric. And then on the far right here is the actual implant. So you can see the components that go into the shin bone, the thigh bone, and then the plastic insert becomes the new cushion for the joint. This is a diagram of that. You can see diagrammatically here with the three main components of the knee replacement. And then this is a slightly different concept, but I wanted to at least include it here because I know a lot of individuals had some questions about it, but partial knee replacement is different than total knee replacement. And you can see that immediately on these x-rays here, but the far left shows a patient that has arthritis that is really quite limited to the inner part of the knee. And at that point, we would get an MRI and we look at that knee in more detail to see if in fact there's no arthritis on the outer portion of the knee, the patient may be a candidate for a partial knee replacement. This implant is shown on the far right, and basically it is exactly as you see in the x-ray. It replaces just part of the knee. There's a lot of benefits to this option, as it does give patients a more natural feeling knee in comparison to a total knee replacement, which at times can feel a bit more mechanical. It's also a less invasive procedure, and so therefore the recovery is a bit easier and more rapid.
Dr. Ponzio, we have two more questions. First one is, what brand of replacement device do you primarily use and or recommend? And then the second part is, how long does a replacement last?
So in this image here, this is called a DePuy Attune knee replacement. And so that's the one that I choose to use for total knee replacement. The particular one in this image is called a press fit knee replacement. So you can see that very gritty back surface on it. So this is actually designed to not use bone cement, but rather to be implanted very tightly up against the bone such that the bone can grow directly onto it. There are also very similar devices in total knee replacement that look almost identical to this, but without that rough surface, that are designed to be cemented in place. And that's a determination that I make during the surgery based upon bone quality. So there's a lot of variables that we can adjust during surgery. And then all of these implants come in so many different sizes and widths that we can really alter all the finer details to make sure that we're recreating the appropriate anatomy for an individual patient. The partial knee replacement that I use in this image is known as the Zimmer Persona partial knee. And I think that every surgeon ultimately is going to develop their preferences for one reason or another. Certainly there's a number of really sort of top companies when it comes to joint replacement across the board that are well recognized and have good track records. And so some of those details as to why a surgeon may choose one over another come down to how user-friendly they are, the instrumentation, what they've become familiar with. And really, when it comes down to choosing those kinds of things, you want to have your surgeon be using the same implant over and over and over again so that it's very consistent and they know all the ins and outs of the implant that they choose to use. Any other questions there? All right, so then we'll get into recovery a bit, and this is more specifically geared towards total knee replacement rather than the partial knee replacement. So total knee replacement, I think, is a little bit more involved than a hip replacement. If you compare the two in general. So I'm breaking this down into phases. For the first 6 weeks, these are some of the details. Typically, patients are going to stay in the hospital one night, and some patients decide to go home the same day. Again, you can put full weight down on that leg immediately. We use a blood thinner, which is baby aspirin, twice a day for about 6 weeks. And again, that's to protect you against blood clots. The common things, though, during the first 6 weeks that you're going to experience after knee replacement include pain, swelling, and sometimes bruising in that lower extremity. So one of the big issues with knee replacement is that you really have to work a bit more to regain your range of motion. And so the pictures that are on this slide show you some basic exercise where you're going to practice straightening that leg all the way out and then, of course, bending it the other direction into flexion. The goal that I give people is to reach a range of motion from about 0 to 90 degrees by 4 weeks after surgery. And really the critical time period is that full 6 weeks. And by the end of 6 weeks, I'm looking for patients to be beyond 100 degrees of flexion and hopefully as close to about 120 degrees of flexion as they can be. But it can be difficult because you do have pain through that experience. You've just had surgery. You have an incision that's healing. You're working with a physical therapist who's pushing on your leg. So I think an important take-home point is that total knee replacement is challenging, and I think that surgeons ought to be upfront with their patients that it's going to be painful at times during that initial recovery. The other thing is that if you do too much too soon, you're going to swell more than average. And so I often tell patients to really take care of themselves during the first 2 weeks to make sure that they're elevating the leg, icing the knee, and doing what they can to limit swelling so that when they go to therapy, it is productive. And then once you get over that initial 2-week period, things generally start to trend in a better direction. In terms of driving, similar to the hip, it's an average of around 3 weeks. And again, the majority of patients can return to sedentary jobs in that 6-week time frame, while more demanding occupations should take a little bit longer before you feel ready to do that. Phase 2, I'll call 6 weeks to about 3 months. And in this time frame, you really should be getting away from needing any type of pain medication for your knee. You may need an occasional anti-inflammatory, and you should expect that there should be some swelling, but it really would be limited to the knee at this point in time, rather than diffuse through the entire extremity. It also is activity related, so the more that you do, the more swelling you may get around the knee, and the remainder of the leg should begin to look more normal. And then long-term is phase 3. So the important things here to take away are that knee replacement may not take away all of the pain. It certainly should be a device that gives you a knee that is better than the knee that you had coming in. But it is not uncommon for patients long-term to still feel little aches or pains here and there, and occasionally need to take an anti-inflammatory. A knee replacement can make noise, so it is a metal against plastic device that can click against each other. That dissipates with time, but it does make noise, and sometimes patients will notice that and comment on it. It can swell occasionally, particularly with a lot of activity. It can look larger than the other knee. Stiffness is something I think that some patients have a difficult time with. And so I really do emphasize regaining range of motion early and making that a priority. When it comes to physical activity, there are patients that can do quite a lot with their knee replacement, very aggressive activities. There are patients that run, that play a variety of sports, that get back to skiing. But I do want to point out that there are a subset of patients after knee replacement that feel that their knee is still more mechanical, a little bit unnatural, and they may not have a high predilection towards returning to some aggressive athletic activities. It can take a little bit longer than a hip replacement, I would say up to 18 months, before a patient really feels that their knee is normal and that they're comfortable to getting back to their activities. Question there?
We do have another question that came in. Actually, two of them. It says, if I wanted to do both knees at the same time, is that recommended or discouraged? Mm-hmm. And then it talks about, do you do anterior or posterior hip replacements?
Okay, so I'll take the knee question first. For both knees at the same time, in general, I would say that I discourage it. And the reason is because it's a lot of surgery for you at one time. You really have to be sort of the perfect patient in order to take that on. And that means that you have to be healthy with not many medical comorbidities, because surgery is going to be longer. You're going to be under anesthesia for quite a period of time. And then the other thing you have to be is motivated. So you have to be the type of person that's really a go-getter and prepared to manage yourself in a smart way to minimize the swelling, elevate, and go through the rehab on both sides at once without really a good leg to stand on during that transition. So I think that if you are in that category, then it's something to consider. And there's certainly patients that I have done that for that are very happy with that decision. I'm also always happy to introduce you to some of those patients that would be able to give you a synopsis of what their experience was like. But if you're on the fence and you're not sure if that's you, then I think that certainly taking one at a time and making sure that it is as good as it can be before you go on to the next one is a very safe approach. With regards to hip replacement, I do the vast majority of hip replacements through an anterior approach. So that's making the incision in the front of the hip. And that is sort of the most popular way of doing it these days. If you were to look online and do some reading, it is thought to be more minimally invasive. It is thought to be a quicker recovery. I always caution people to follow those lines of thoughts because a lot of marketing is involved in that kind of thing. I also do the hip replacements from the posterior approach, where we make an incision on the side of the hip. And really, I make that determination on an individual basis, dependent upon where the patient carries a lot of their soft tissue. If they have a large belly that sort of hangs over the area where that incision is going to be in the front of the hip, then I may tell them that it is safer or a better idea to go from the other approach, just to make sure that their incision can heal without any problems. So there are also some other details that I look for on the x-ray that may dictate one approach being better than the other for a particular individual. So I do both approaches, the grand majority anterior. Any other questions?
Yeah, if we can only do one knee, how long before the second knee?
Yeah, so the minimum is 6 weeks. So at least 6 weeks to allow you to complete the physical therapy for the first knee, and then you can go on to do the second. So moving on to this slide, this is a common kind of image that you'll see of joint replacement. And all these are actually joint replacement patients getting back to their physical activities. So many patients come in and they want to know, well, what can I do after surgery? And I think that's an important question. And unfortunately, the answer is not always so black and white. Certainly, we know that joint replacement gives you the opportunity to maintain or restore a fulfilling, enduring athletic experience. If you look at research that's been done and surveys of patients, returning to sports occurs in about 60 to 90% of cases after joint replacement. And that variety comes from different studies that we're looking at. And of course, the recommendations in terms of returning to certain activities are going to vary for each individual based upon their general health, the type of implant they have, what their pre-surgery athletic experience was, and which types of activities they're looking to get back to. If you look at surgeons across the country and even across the world, surgeons always will encourage low impact activities. So things like walking, stair climbing, cycling, swimming, golfing, hiking, bowling, dancing. These things are encouraged. Other activities are also encouraged in athletes with experience, and those would be things like rowing, skiing, tennis, ice skating. It's the activities that create high joint loads where we have some concern, and so that means that we're putting a lot of pressure and force through a joint. And the concern is that can you potentially wear that joint out early or cause complications that are mechanical in nature, like causing the joint to loosen from the bone. Those activities would be things like running, racquetball, squash, martial arts, water skiing, more aggressive skiing like mogul skiing, snowboarding, powerlifting, or sports that have high contact potential. So football, soccer, hockey, basketball. So in general, my approach is really patient specific. So depending upon the things that I mentioned before, your experience in these particular activities is really important. I have patients that have gone back to many of these more aggressive sports, but they have to have some knowledge and experience in those sports beforehand. And every patient is different. Some patients, their goal is really to get back to quite simple things, walking, just living their lives, going up and down the stairs with one foot going over the other rather than one at a time. And so, I am a real proponent of physical activity. So my goal is to help you get back to doing the things that you want to do. So I don't restrict any particular activity, but I do think as a patient, it's important to understand what the potential limitations may be after a joint replacement. After hip replacement, I would say that the restrictions are much less, or the possibilities are more, maybe I should say. So this is a patient of mine who just last week was involved with the 5K that we put on. It was a virtual event through Rothman. And she was 1 year out from her total hip replacement. And she sent me a message saying that she ran her fastest 5K ever a year after her hip replacement. And so she was really excited and I was thrilled for her. But I put this here because hip replacement does give you a higher level of comfort and agility because it is such a natural device when you replace a ball and socket joint, that patients typically can do things that are a bit more aggressive in terms of athletics when you compare it to a patient that's going through a knee replacement. So in conclusion, physical activity before surgery, the main things that we emphasize in patients that have arthritis in their knee or their hip are to continue doing things that involve strengthening, low impact aerobic exercise, consistent activity, and anything that you can do to maintain a healthy body weight. So we know that all of these things help arthritis and help lessen the pain coming from arthritis. During joint replacement, and when I say during, I really mean that first 6 weeks, that time frame is going to be a much more slow, careful process where you're trying to make progress, of course, but being aware of the potential obstacles like swelling in the extremity. I ask patients to use common sense and to really let their body recover so that that joint can be something that gives you a lot of potential for activity for the long term beyond that initial 6 weeks. In the early time, you're going to be emphasizing range of motion, stretching, and walking, and really keeping it quite simple. After surgery, that's when I think individuals should really consult with their surgeon to determine what athletic activities fit their lifestyle and their goals. And I think that you can expect an excellent return of joint function and relief of your arthritic pain, And then from there, the question is, how far do you want to push that? And certainly we have patients, like I said, that are quite aggressive about participating in a number of athletic activities with a lot of success. In general, for the general population across this entire spectrum, you should be aiming for that 30 minutes of activity about 5 times a week, with strengthening activities about 2 times a week. And I think if you can start to incorporate that into your day-to-day routine, if you're not already, that would really be beneficial for the health of your joints going forward. As a resource, this is a web page that is based upon the American Association of Hip and Knee Surgeons, and I've put the web page there at the bottom of the screen. We can also send that information out to you, but I think that this website has some really reliable information. It gives you actually videos of different exercises that you can do before surgery, after surgery. It gives also printed out forms where you can look at PDFs of different images to show you some variety of exercises, and also answers a ton of questions. And it's a reliable source that we use even as hip and knee surgeons across our country. So I'm happy to take any final questions. I'm also happy to answer individual circumstances or address individual circumstances through email. My email is listed here. I have an Instagram account that I post some interesting cases and things on there if anyone's interested in taking a look at that. And then, of course, I'm happy to see you in person if you have individual circumstances that you'd like to have evaluated in either Egg Harbor Township, Cape May Courthouse, or Manahawkin. And thank you all for joining us this evening.
Dr. Ponzio, before we conclude tonight's event, a couple more questions in here. One asks about bicycle rides. I'm not sure if it was for hips or knees, but what are your thoughts on cycling for both joints?
Yeah. So I think that's a really great sport, so whether you have a joint replacement or not, it's a rather low impact activity that allows you to achieve high levels of fitness and to push yourself through a range of intensities. You can be a low intensity bicyclist, or you can be, road biking. And I think I'm really in favor of biking for joint replacement patients as well as patients that are pre-joint replacement. And that's for hips and knees.
And then how about as far as equestrian sports? Are patients able to do that post-surgery as well?
Yes, I think that's also a sport that you can participate safely, and that would be, something I would allow patients to return to.
Let's see, what else do we have here? Somebody writes in, I'm coming up on 2 years since total hip replacement and experienced discomfort in the morning once up and exercising subsides. Is this normal?
This can be normal, and part of it, of course, could be related to just normal aging, as in the morning in particular, before you get going. And then as you use the joint, and really not the joint replacement itself, but the muscles around the joint replacement that need to loosen up and get feeling better throughout the day. But if you have concerns, I do recommend going to get checked out by either your surgeon or another surgeon to make sure that you've looked at your x-rays on some routine basis to make sure that nothing has changed and that everything is well with your joint replacement. Mm-hmm.
Any other questions? Looks like we have one more. It says, I had a posterior full left hip with Rothman 3 weeks ago in Hackensack. I feel great and haven't used a cane at all. Is that okay? Return to work this week. I have a sedentary job and it is a little tough, so I'm not doing as many hours sitting.
Okay. Yeah, so it is okay to not have used a cane. And I have patients do the same thing. I tell them to use it for 6 weeks, and often they'll come in carrying it in their hand saying, I don't really need this. But so that's okay. I think the point to take away is that you should try to sort of keep yourself from doing too much too soon, and that making sure that you don't take a step backwards. Just taking it slow in the first 6 weeks, because your implant on the inside is still healing, within your body. And even if you feel great on the outside and you feel like you can do things, it's only to your benefit to allow it to heal completely before you really start to push the limits.
Awesome. And then I had two people ask in regards to the PowerPoint and the website that she posted. At the conclusion of this talk, I am going to put a message together. I will send out those websites. I would be happy to share her PowerPoint if she's open to that as well. And I will also be sending out the recording for this presentation as well. So all of those resources will certainly be available for everybody here. Any other questions before we wrap things up? Is there a downside to posterior replacement?
So I will tell, the answer is no, not a clear downside, but I'll give you a little bit of my impression on this. So I do both anterior and posterior, so I think I have a pretty fair take on the two. Some surgeons only offer one. They only do hip replacement one way. And so if you go to a particular surgeon that only offers one, that's what you're going to get. Across the world, the majority of surgeons are doing posterior hip replacements. The number of people doing anterior hip replacements is increasing over time. But just so you realize that even though the anterior approach is getting a lot of publicity, posterior is still sort of the tried and true way of doing a hip replacement. And it's been around for a really long time. It's a successful way of doing hip replacement. The potential downsides, if you look at all of the numbers, are that there's a risk of dislocation after a posterior hip replacement. That is the ball popping out of the socket. It is slightly higher than an anterior approach. So we're talking like 1.2% compared to 0.5%. And so that risk differs. However, there's always a trade-off. An anterior approach has its own set of risks. And so it's a balancing act that the surgeon has to make the right decision with the patient to say what is really the right thing for that individual person.
Awesome. Thank you so much, Dr. Ponzio. If there's no more questions, that concludes our event for tonight. Thank you, everybody, for joining us in this new virtual world. I appreciate you taking the time to hop on with us. As always, you are welcome to check out our website. It's rothmanorthopedics.com. We have a load of resources on there. As Dr. Ponzio mentioned, she does have an Instagram that she's started as well. So check her out there if you're an Instagram person. And she's always open to email as well. So any questions, feel free to either shoot her an email or give us a call. She did post our 1-800 number there. And again, thank you so much, everybody. Enjoy the rest of your evening.
Thank you.